So today we're going to complete the third portion of pulmonary. So we left over on the auscultation portion. Remember that bronchial breath sounds are best heard at the level of the sternal notch, second intercostal space next to the sternum. If you hear bronchial breath sounds anywhere outside of that area, interscapular, where you should hear vesicular, bronchovesicular, is completely abnormal. So if you hear bronchial breath sounds anywhere outside of the parasternal area in the second intercostal space, you might think about a consolidation process. Remember that consolidations are basically patients that have pneumonia, okay? So besides being able to hear bronchi through auscultation, the vesicular breath sounds that are normally heard on a normal lung tissue is not present. Cavitary lesions, for example, patients that do have tumors, like a squamous cell carcinoma of the lung or small cell carcinoma of the lung, that tend to produce cavitary lesions, or tuberculosis, as well as fungi that tend to produce cavitary lesions, or septic emboli in the lung that also can produce cavitary lesions. You would hear mostly bronchial breath sounds, which is abnormal. Again, the only area that you can hear bronchial breath sounds being normal is at the second intercostal space next to the sternal notch, parasternal. Okay? Or, for example, if you have a tumor, as previously stated, or if you have, for example, a patient that has an atelectasis, which is basically closure of the alveoli or complete collapse of the alveoli, you can also hear bronchial breath sounds. Okay? So, as well, remember that when we are trying to see how the voice is transmitted through auscultation, you can tell the patient to muffle or just say a word. Normally, this voice will be transmitted very, very soft and very indistinct through auscultation. If at any point in any particular foci of the lung, you can hear the voices very loud compared to other areas of auscultation in the lung, that is called bronchophony. And bronchophony is very, very pathognomonic of patients that have pneumonic process. So pneumonia, you can have bronchophony. When you tell the patient to say E, and you are auscultating and the voice is distorted, and instead of hearing an E, you hear an I, most likely that is abnormal and is present as well in pneumonias, and that is called egophony. Okay? And at the end, you're going to tell the patient to whisper any word. You should not hear, or if you're able to do so, it has to be, again, very soft, very indistinct meaning of the word. Sometimes you cannot understand exactly what the patient is telling you, but if you're able to hear clearly what the patient can say while whispering, it's called whisper prectoriloquy. So patients with pneumonia, they tend to have 3 pathognomonic signs that, even though it could be present, for example, in patients that have tumor, because as well as a consolidative process, is most commonly present in patients that have pneumonia. So bronchophony, egophony, and whisper prectoriloquy is pathognomonic of patients that have pneumonia. So what is an adventitious breath sound? Adventitious breath sounds is a sound that is not normally present in the lung. You should only hear vesicular and bronchovesicular breath sounds in the back and bronchial breath sounds in the second intercostal space. When you hear bronchi is basically no more like a rumble type of sound that is present when the patients have lots of secretions. That is mostly continuous and musical. Wheezes, we already discussed, is basically a high-pitched sound. It's also musical. It's mostly in expiration because there is an obstructive process. It could be bronchospasm, such as in asthma, or it could be, for example, a mucus plug, or it could be basically secretions blocking the airway, or an atelectatic process blocking the airway. Patients would have this also musical sound, and most likely again is, for example, if you have a narrow airway by bronchospasm or an obstruction of mucus plug or foreign body, you can have wheezes. We talked about rhonchi, rails or crackles. This is a sound that is highly produced in inspiration. You have two types of rails or crackles. Fine rails, mostly in inspiration, present in patients that have volume overload states, for example, in CHF patients that have pulmonary edema or pleural effusions. Dry crackles or coarse crackles, most likely in both phases of inspiration and expiration, highly present in patients that have pulmonary fibrosis. And this type of crackles, you might compare them with the sound of a Velcro. When you're trying to open or close a Velcro, it sounds exactly like dry or coarse crackles. Again, highly present in patients that have pulmonary fibrosis. So basically, again, adventitious breath sounds is not normal. This is completely abnormal breath sound. What is a stridor? A stridor basically is no more than when there is an obstruction of the upper airway. The patient is able to take a normal inspiration, but by the time the patient is trying to expire and the air passes through the upper airway, in this case the trachea, or with at the level of the epiglottis or the larynx, so basically posterior pharynx, the patients would have this loud sound. And again, it basically indicates obstruction of the trachea or the larynx. Highly, as an example, or highly frequent example of a stridor is in patients that have, for example, anaphylactic shock, that the airway swells up due to hypersensitivity reaction type 1, mediated by mastocytes releasing histamine, produces a dilation of the airway and blockage. Therefore, the patients can have stridors, and you can treat that with epinephrine or racemic epinephrine nebulizer. Of course, Benadryl as well as H2 blockers. In addition, if the patient has, for example, an epiglottitis, that most commonly is present due to either a viral condition or streptococci group A. Beta-hemolytic patients tend to have, again, an airway closed. Patients are restless, they can't have a normal expiratory force. Patients are in respiratory distress, having intercostal retractions, a sternocleidomastoid. They have a mouth open. Therefore, they tend to produce a lot of salivas and they drool. And when you auscultate the patient at the level of the neck, the patients do have a stridor. Another sound that is highly prevalent as a normal sound is called mediastinal crunch or Hammond's sign. This is no more when the patients have subcutaneous emphysema by any kind. If the patient has, for example, a pneumothorax, there's leakage of air at the level of the subcutaneous tissue, and when you press on a patient or auscultate by pressing with a stethoscope, you're able to hear air bubbling under the skin. So in addition to that, when, for example, the heart is beating, you can also hear air at the level of the mediastinum. And this is, again, no more than when the patients have, for example, pneumomediastinum that is produced by high pressure at the level of the organs in the intrathoracic area. For example, if the patient has high levels of PEEP, because they are, for example, in ARDS, High levels of PEEP can produce increased intrathoracic pressure, being positive in this case, and it can produce leakage of fluid, of air at the level of the subcutaneous tissue as well surrounding the mediastinum area. And that produces exactly that sound. Patients, when they have hyperinflation due to status asthmaticus or respiratory failure or COPD exacerbation, they can only have leakage of air at the level of the mediastinum or subcutaneous tissue, and you can hear that sound. If you have retching, vomiting, or coughing, there is esophageal rupture. So when the patients have esophageal rupture due to retching, or that happens very frequently in patients that have gastroenteritis, or patients that have bulimia, or if you do now an EGD and iatrogenically you rupture the esophagus, patients can have also air being leaked to the mediastinum or subcutaneous tissue. If you do Heimlich maneuver or do any traumatic procedure or motor vehicle accident intrathoracic, that can produce the same problem as well. And as I said, you know, if you have any iatrogenic procedure, for example, you're doing thoracentesis and there is leakage of air because you produce a pneumothorax, that can produce not only mediastinal air or what's called pneumomediastinum or subcutaneous air at the level of the interspace of the epidermis and the hypodermis. Again, patients that have emphysema, rupture of the bulla, can also leak air in the mediastinum as well as the subcutaneous tissue, etc. So you don't need to memorize this table. It has been explained already, but I will go one by one again. Remember that the normal breath sounds are vesicular breath sounds, and when you tell the patient to talk and you palpate the posterior aspect of the chest or anterior aspect of the chest, it has to be symmetric and equal distribution and vibration. Adventitious breath sounds are completely absent in a normal patient. When you have any type of consolidation, either because you have a blocked airway, or you have a tumor, or you have a consolidation pneumonia, breath sounds tend to be more bronchial. You have agophony, you have bronchophony, you have whisper, pectoral locking. In addition to that, any inflammation or infection can produce leakage of fluid to the outside. So yes, it's not wrong that patients with pneumonia can have rales or crackles, even though they can also have bronchitis and wheezing. Wheezing is most commonly prevalent in patients that have asthma. The breath sounds are completely vesicular. The voice transmission tends to be completely normal. And again, patients tend to have expiratory wheezes. In interstitial lung disease, I want you to concentrate in patients that have pulmonary fibrosis. So the breath sounds are completely vesicular, so completely normal. The voice transmission is normal, and crackles are present, but remember, these are not fine crackles of CHF. These tend to be coarse, dry crackles, like Velcro-like type. Patients with emphysema, the breath sounds, remember, that are diminished. There's a lot of air being present. Voice transmission, remember that the voice fly, but they don't fly as well as they walk. So therefore, the voice transmissions are decreased, and the adventitious breath sounds are completely absent, but they tend to have either bronchitis or wheezing. Remember that patients with emphysema or COPD, they tend to have chronic bronchitis with a lot of sputum production, so that's the reason why you can also hear crackles. In a patient with pneumothorax, remember, it's a lot of air trapping, even though it's a lung collapse or lobar collapse. So since there is also air trapping, the breath sounds are decreased, and the voice transmission during air accumulation, they fly, but not as well as they walk, so that's the reason why they're decreased. and the adventitious breath sounds are completely absent. Pleural effusion, remember this is fluid. The voice are either decreased or absent. Remember they tend to drown. So breath sounds are decreased. And in addition to that, the adventitious breath sounds are best heard are crackles or completely absent. Now, going through the breathing patterns, completely normal breathing pattern is called eupnea. So the patients are having a normal rate and depth of respiration. I want you to concentrate on the difference between tachypnea and hyperpnea, which is basically the same as being rapid. So the rate tends to be increased in the patients with tachypnea, but the depth of respirations are not as deep. This is more superficial than hyperpnea. Patients with bradypnea, of course, the rate is decreased. Patients with apnea, there is absence of breath sounds. Patients with Cheyne-Stokes respiration, biot, and apneustic type of breathing tends to be more central when the patients have either neurological damage or due to stroke or traumatic brain injury or increased intracranial pressure of any source. Patient with Cheyne-Stokes respiration, I want you to concentrate as they have tachypnea, hypopnea, and apnea, versus patients that have biorespiration, they tend to have only tachypnea and apnea. Patients with apneustic breathing, this is no more than a prolonged inspiratory phase with short expiratory phase. So basically the patients have also tachypnea, but the expiratory phase is shortened. And again, this is most commonly produced, these three, Cheyne-Stokes, biots, and apneustic breathing in patients that have any type of brainstem damage. Kussmaul respiration is basically tachypnea and hyperpnea. This is basically present in patients that have metabolic acidosis as a compensatory mechanism. So after you do an examination of the anterior chest, remember that the area that we tend to assess the most in the anterior chest is the second intercostal space for auscultation, because the breast, for example, in the female, and the mediastinum, where all the main arteries and veins as well as the heart are located, that interfere with the sounds that we're looking for. So mostly the second intercostal space. The posterior aspect of the chest, you do exactly the same order: inspection, palpation, percussion, and auscultation. And you do this in a ladder pattern. So palpation in a ladder pattern and auscultation as well in a ladder pattern. Okay? Remember that when you're going to percuss, you basically use the middle finger and you try to elevate the palm of the examiner from the chest of the patient. So never rest your hand on top of the patient's chest. You have to put your middle finger and erase the palm of the hand away from the patient's chest and use either 2 or 1 finger of the percussor hand and percuss. These fingers as well are never rest on the patient's chest. Okay? So what you should hear normally through percussion is resonant sounds, because there's air behind. You do it in a horizontal pattern, never percuss vertical. You basically will be looking at the intercostal space and percuss. And you have to do this in a ladder pattern. If at any point you hit a rib or a bone in the scapular area or the vertebra, you will hear dullness to percussion. And that is because the bone is solid. And that's exactly what you will percuss or hear when the patients have either a tumor, or when the patients have a consolidation pneumonia, or when the patients have pleural effusion. Flatness or dullness to percussion. This is basically to assess the chest expansion and excursion. You could do it anteriorly and also posteriorly. So basically you put your hands and you put your middle fingers. This basically will be the costal angle where the last rib finished. So you will be looking at the xiphoid process and put your fingers right there. And tell the patient to take a deep breath, and these fingers should separate symmetrically from midline. If one moves and the other one doesn't, that means that this area that doesn't move properly has a disease process, either pleural effusion, a tumor, or any consolidation pneumonia. When you're going to palpate fremitus, put both hands in the anterior chest and tell the patient, say 99, 99, 99. And remember, if it's consolidation, the voices are transmitted increased. If there is a lot of air, such as in asthma or pneumothorax, they're decreased. And if there's fluid, they decrease or abolished because they drown. Auscultation has to be in a ladder pattern, so you either start on the right or the left, but you have to do 1, 1, 2, 2, 3, 3, 4, 4, 5, 6, 5, 6. That is called ladder pattern, L-A-D-D-E-R. If you're going to percuss in the anterior chest, for the women, you have to raise the breast and look for the intercostal space. We only do percussion for the assessment in the second intercostal space. So again, when you're going to inspect the patient's chest, first look at the symmetric of rising and inspiration. It has to be symmetric, equal, rising through inspection. Sometimes when you walk into a patient's room, you can hear the patient coughing, and that will be the main complaint that you will be concentrating on. And ask the patient if they have any type of sputum production and the quality of that sputum, the color, the consistency. You can actually see it sometimes at the bedside. If the patient have, for example, any delay of expansion, when you tell the patient to take a deep breath and you observe, again, that could be fluid, that could be a pneumothorax, that could be a consolidation. In other words, that means that that particular space is diseased, okay? Look at the respiratory pattern of the patient. If the patient is short of breath, you can see if the patient is having tachypnea or hyperpnea. You can also see, if you uncover the patient's chest, if the patient has retraction intercostal or the sternocleidomastoid. If the patient is using abdominal breathing. Look at the patient's cyanosis or any type of totter at the level of the fingers that indicates that the patient smokes. Look at the patient's finger and see if there is peripheral cyanosis or if there's clogging. Okay? In palpation, again, you're going to do chest excursion and expansion and see if there is an asymmetric movement of one that indicates a disease process. You're going to palpate as well the chest, and you're going to tell the patient, say 99, and again, the voice transmissions are increased in consolidation pneumonia or tumors. The voice are decreased in air accumulation, such as asthma, for example, emphysema, patients that have pneumothorax, and the fremitus are absent or decreased in fluid, so in pleural effusions or patients that have pulmonary edema, okay? So in addition to that, if there is a pneumothorax, tension pneumothorax, besides the hemodynamic instability of the patient, you might see tracheal deviation as well. Okay? Percussion. Remember that percussion should be resonant in the intercostal space. If it's not resonant and there's flatness or dullness to percussion, there is a disease process, which it could be, of course, a tumor, it could be a consolidation pneumonia or fluid. Okay? Through auscultation, remember that the breath sounds are, the majority in the posterior chest wall is vesicular. Only the interscapular area is bronchovesicular, and at the level of the sternal notch is bronchial. If bronchial breath sounds are present throughout or in a particular foci besides the second intercostal space, that is completely abnormal. Okay? So if we went already through the table, when is decreased, when is absent, and what adventitious breath sounds you can hear. For example, in patients that have bronchitis, remember that bronchitis could be acute or could be chronic. In acute bronchitis or chronic bronchitis, the patients have increased amount of secretions. This could be viral or could be bacterial, or could be a chronic condition such as in COPD patients, that they tend to have abundant sputum production for at least 3 months. Patients, you could see in inspection that they tend to have a hacking cough and they tend to produce large amount of sputum. But this sputum is not fetid, even though it could be yellowish or greenish color, or as well gray color. You might see that the patient could be fatigued and have shortness of breath. Now, clubbing or cyanosis of the finger, they tend to be more in patients that have chronic bronchitis. When you do palpation, the tactile fremeters are normal because this is only secretions being present. This is not a consolidation. This is not an air trapping. This is not fluid. That's the reason why it is normal. It's only secretions. Percussion is completely normal, and the patients tend to have resonance because the secretions are not going to jeopardize the either auscultation, breath sounds, vesicular, or the percussion sounds. So it's a normal vesicular breath sounds, but they tend to have a little bit prolonged expiration because sometimes the patients with the secretions tend to block the airway. So that's the reason why they tend to have either bronchitis or wheezings. Emphysema, on the contrary, remember this is an air trapping. This is an increased anterior-posterior diameter of the chest due to hyperinflation. So think about emphysema having a lot of air trapped, okay? So that's the reason why patients, when they come with an exacerbation of emphysema, they can come in using already accessory muscles. You can see the patient with shortness of breath, okay, and tachypnea. When you're going to do palpation or palpation of the voice transmission, which is called fremetus, remember, a lot of air trapping. That's the reason why the voice is transmitted decreased, because they fly, but they don't fly as well as they walk. So they're decreased. And percussion, there's hyperresonance because the air sounds really loud when you percuss, okay? And the auscultation, it's not affected. The vesicular breath sounds are still present, but the breath sounds are decreased. And what do they tend to have? Well, they tend to have prolonged expiratory excursion. And if they do have any type of adventitious breath sounds, it's not bronchitis because they don't have secretions as the patient with chronic bronchitis or COPD. They tend to have a lot of air trapping. So the highest of the adventitious breath sounds that they can have is wheezing. Pleural effusion, think about pleural effusion as fluid. So when you have fluid, remember that the auscultation or the breath sounds tend to decrease or drown. So either diminish or abolish. The voice transmission, so the fremetus, I'm sorry. The voice, when you palpate the chest and you tell the patient to say 99, those voice transmissions are decreased or abolished because they tend to drown, okay? So they do have that shortness of breath, of course, when you're going to palpate. Again, your fremetus tend to be decreased or absent. Because there's fluid in one space, when you put your hands in the middle of the chest and you tell the patient to take a deep breath, the side of the chest that has fluid doesn't move as much as the other side. So the area that is affected has decreased chest expansion, okay? And when you're going to percuss, because there's fluid behind, fluid or consolidation is flatness or dullness. And the auscultation, of course, the breath sounds are going to be diminished or absent in the area that the patient has fluid. And patients can have, even though it's highly prevalent and pathognomonic for patients that have tumors and pneumonias, they can also have bronchophony, agophony, and whisper preparatory locking. And of course, they would have crackles. Now, we did study this in pathophysiology, the difference of transudate and exudate. Remember that a transudate is patients that have increased hydrostatic pressure mediated by hypertension as well as cardiovascular conditions. And in addition to that, Transudate are for patients that have decreased oncotic pressure. For example, patients that have decreased amount of protein, which is malnutrition. Patients that have also cirrhosis of the liver or nephrotic syndrome, that the patients excrete large amount of protein through the urine. So basically what we're going to investigate is the difference in ratio proportion between the protein in the fluid and protein in plasma, as well as the LDH difference in fluid as well as in plasma. So we're going to go through different cases in class so you can make the difference. In addition to that, the exudate is no more inflammatory process, infectious process, as well as obstruction of lymphatic drainage. So any inflammation that you can imagine, either locally in the lung or systemic. So if you have, for example, pancreatitis, can produce pleural effusion. But if you have as well pneumonitis or pleuritis, can also produce pleural effusion. Septic patients, by any kind, even urinary tract infection that produces sepsis and septic shock, can produce pleural effusion. Patients with any inflammatory process, again, pleuritis, pericarditis, pancreatitis, appendicitis, any itis that you can imagine can produce pleural effusion. In addition, obstruction to lymphatic drainage, I want you to concentrate on patients that have cancer. But in addition to that, if you have a pulmonary embolism, even though it's not highly prevalent for these patients to have pleural effusions, it is a possibility by pathophysiology. And again, we're going to go through cases to be able to discuss the difference in calculation between exudate and transudate. And again, this is no more than transudate, and you don't have to memorize all this because we already discussed in pathophysiology that a transudate is no more than patients that have increased hydrostatic pressure, hypertensive patients, patients that have cardiovascular conditions, or decreased oncotic pressure, which is decreased amount of albumin, either due to cirrhosis of the liver, patients that have nephrotic syndrome, patients that have, for example, malnutrition. Now, exudate, again, inflammation, infection, or patients that have obstruction or lymphatic drainage. So inflammatory process could be any inflammatory process, even autoimmune conditions, such as rheumatoid arthritis, which is a systemic inflammatory disease. Patients that have infectious process anywhere in the body, as well as cancer. Pneumonia, remember that pneumonia is either a viral condition or a bacterial condition, most commonly present by Moraxella catarrhalis, Haemophilus influenza, and Streptococci pneumonia. That we do have vaccinations against Streptococci pneumonia and Haemophilus influenza as well. But there's more and more bacteria that can produce pneumonias, and as well as viral conditions. We only can prevent influenza A and B vaccination, certain species. So patients that have pneumonia, they come into you with fever, chills, leukocytosis, and sputum production. Most commonly present is yellowish, greenish sputum. And these patients tend to come with shortness of breath. So through inspection, the patients can have, of course, tachypnea, tachycardia. Patients can have, in addition to that, flaring, using accessory muscles. When you do palpation, think about pneumonia as a consolidation, a solid process, that the voices can walk very easily through it. So the breath sounds of the patients are going to be diminished, but the voice transmission, when you do either palpations, such as fremitus or auscultations, are increased, okay? Because they walk really well. So the area that has a consolidation compared to a normal lung, the voices will be transmitted high pitch, okay? And the patients have associated ergophony, bronchophony, and whisper pectoral locking. When you do a percussion, since it's a solid environment, when you're going to percuss, you're going to hear dullness to percussion. And in addition to that, the patients can have bronchi, the patients can have wheezes, and the patients can have crackles, because remember, an infectious process can leak fluid to the outside.